Multiple people have already asked me what a physiatrist is. I'm not a physio. I don't exclusively love feet. I don't do mental health. I mean, I do a little bit. I'm a rehab medicine doctor. If something goes wrong and it affects your physical function, that's kind of what I do. Lots of people I might have met in the crowd because of peripheral nerve problems, all of that. And so when I was thinking about what to do for this talk, because Paula Vollen told me for it, I was thinking about what is something commonly that I see that I think also affects the majority of people in our lives. Statistically, it's proven. And so I thought, low back pain, let's talk about it. Pretty much my goals for today are to dispel as many myths as I possibly can about low back pain, and to prove to most people that most low back pain is not scary, dangerous, despite it being one of the most common debilitating conditions that people have. This is the medical definition of low back pain. It is pain that happens somewhere between the bottom of the rib cage and the top of your bum, where your low back is, right? There's multiple different pieces of all of that. Some people will talk about sciatica, that is low back pain that radiates somewhere, but the whole point of it is that it's somewhere anatomically where we all think of our low backs. Why is that important? Well, I do a lot of thinking about anatomy and what the underlying pieces of the thing that could be painful and thinking about that. So again, it's not your mid-back or where your trunk is. It's not your neck. We're talking only about the low back. Low back pain is incredibly common. It is, as we were already chatting about, one of the most common reasons why people would go see their family physician, why they might stop into an emergency department. It is the most common reason why people lose days of work and why they might become disabled. So common problem. Vast majority of us, 84%, if you got that on an exam, you would be thrilled. That is a huge amount of the population. And not just that, almost half of us in the last 6 months will say, I've had a bout of low back pain that was enough that they mentioned it in common surveys. There's a number of different things that can cause back pain. My role as a physiatrist, in terms of thinking about, again, medicine that is functional, medicine that is based on movement and those sorts of things, I tend to ignore medicine, and family doctors are really good at saying, oh, this is a kidney stone. Oh, this is something else. And by the time I end up seeing someone, it's going, there's a number of other things in the background that can be causing this. And I'm sure all of us have been told by a friend or another, you're like, oh, my back's bugging me. And they start telling you about their fancy chair, or, it's because you fell, and, school of hard knocks, all of those things. We've all been there. Most commonly, no one actually can tell you why they have back pain, right? It's just there. You wake up one day and you have it. And you're like, what did I do yesterday? You're racking your brains going, did I shovel one too many? Thankfully this is melting. And so again, multiple causes, maybe it was 100 different things, the cherry, the straw, we don't know. When I think about back pain, I think about anatomic structures that can cause pain in someone's back. There are a whole bunch of structures that don't really cause pain. They're not on this list. But if you think about what the back is, right? It's stacked vertebrae, one on top of the other, right? I didn't bring my spine in. It wouldn't be big enough to see anyway. But it's stacked vertebrae, one on top of the other. Between those bones are discs, right? And once upon a time, we were quadrupeds, then we stood up, and the mechanics of that changed. And so this whole thing stacked on top of each other has these bones that have joints in between them and discs in between them. And then if you think about that, If there's discs and bones, there have to be joints. And if there's joints, there's ligaments, right? Those soft tissues that support those things. And then there are dozens and dozens of muscles that support that too. If you wanted to nerd out with me and Deanna, we can tell you probably about, 100 different muscles just in the back alone? Point being that, again, when I think about this, I'm thinking about dozens of different structures that can be involved. And they all have to work together to make the back move and function. And they all can change over time as we age, as maybe you did fall at one point and have a trauma, all of those things. In terms of aging, we all hope to do it gracefully. I don't know if you've heard my term. I like to say we should age gracefully like fine cheese and fine wine. I don't want to be a stinky cheese when I get old. But the idea is how does that work? What changes? And a few things change. If you think about the difference between a fresh cheese and an old cheese, the old cheese is a little bit dehydrated, right? It's a firmer cheese, unless you're blue cheese. But we dehydrate as we age. It happens. So if you think about a disc, if it's a squishy bit of jelly donut and that dehydrates, that's one of the reasons why we get shorter as we age, right? Bone, disc, bone, disc, bone, disc. And if the disc gets smaller, we're going to get shorter. Well, that changes the mechanics of the back, right? I already have arthritis. I assume everyone in the room already has a little touch of osteoarthritis. When that happens, the bones grow. They hypertrophy. They get bigger, right? Thinking about knobby knees and knobby knuckles. What if that happens in your back, right? I said each of those bones has joints in between the other ones. Those joints get bigger. They hypertrophy. How does that change the mechanics of the back? What happens there? Well, again, maybe that's going to push a little harder on a nerve and encroach on it and cause pain. Maybe the joint itself, just like our knobby knees and our knobby knuckles, can hurt. And then if we talk about structures dehydrating, like discs, that's when disc disease can happen. And the jelly in the donut can move out and squish out and cause problems or push on something it's not supposed to push on. The other bit is all of those soft tissues, muscles, ligaments, they dehydrate too, or they become a little less flexible, or you go from being the person that had to run around after small children and, be crazy active, and maybe the strength of them goes down a little bit because they're not used to being as robust. And so all of those little changes, again, I talked about multiple muscles and multiple bones stacked on top of each other and multiple discs. They all have to interact and work together. And so tiny changes can make big changes because they all start to compound. And so that's why, again, if you think about back pain being so prevalent, we all have at least one arthritic joint. And then there's so much going on in the back, it's kind of not surprising, again, that who are these 26%, right? The things I'm not going to talk about today, but that can actually affect back pain are these things. And the reason why I have them all coming up individually is because they are important, right? If you have bad hips and bad knees, you are going to put extra pressure on your back. Same thing if you've got bad feet and bad ankles. I am not a family doctor, so I don't talk about kidney disease when we're talking about other systems. There's other things that can cause back pain that aren't mechanical back pain. Not today's topic. One of the constants in life is that life is constantly changing. And when you think about your back, there are constantly things that can change about it or get affected. And that's the same logic here when I talked about slight structural changes as we go. And so again, say you have a little bit of wear and tear arthritis, and that changes the way that muscles pull around the joint because they're trying to protect it. Well, does that mean, Bob is stronger than Carl, and so then Carl starts getting upset? Carl's a muscle. and then that changes the disc and all of that and so on and so forth, right? What do you guys think? What risk factors increase the risk of back pain becoming chronic? So you get one bout of it, say you had a slip tumble, and then what's the likelihood that that's gonna become a chronic problem for you, become the type of thing that you wake up with, unfortunately, more days than most, or what have you. You can have 10 out of 10 back pain. Not a risk factor that it's gonna become chronic. Obviously, if you have a broken back on an x-ray, bad news, but we're talking about those age-related changes, right? Those wear and tear changes. People saying, oh, you've got facet arthropathy or spondylosis,
Can you spell that?
No.
Is that real?
Yes. But these terms that people go, whoa, like I've got a disease in there. Age-related changes is what all of those things fit under. And at the end of the day, those findings on an MRI, a CT scan, or an X-ray actually don't correlate with someone's pain severity or someone's pain chronicity. Some other things that do increase the risk of back pain becoming chronic. I think obesity and smoking are on this list as they're both pro-inflammatory. They're also both related to things like mental health, mood, anxiety, things like that. I am not a smoker, but I have found that smoking is the best anti-anxiety medication most people tell me about. And so is there a relationship there? The answer to that is yes. So to me, I think obesity and smoking fit very much in the whole relationship between physical and mental health. Speculation, no evidence, but they're on the list in terms of evidence. Extremes of exercise, both extremes. So again, everything in moderation, right? Moving somewhat, but you don't have to become an ultramarathoner. You don't have to become that like crazy Pilates person, even though I very much believe in Pilates, right? Just some. All right. And again, I'm gonna keep hounding this. If anyone wants to know what the theme of my talk is, it's that imaging findings don't correlate with back pain. To drive it home, because I spend a lot of time daily talking to people about the pathology of their imaging findings, these age-related changes, as I talked about before, include facet joint degeneration, which causes what's called neural foraminal stenosis. I'm using the big words because I think a lot of people at some point in their life have had back imaging and have heard these things that are in Latin, and so we don't understand them. I should have taken Latin. It would have really helped in medical school. But the point is that like there are these big medical terms, and it seems like there's pathology there, but there's no relationship. That these are just age-related changes that happen and that are the normal part of the aging process to the back, and they're not related. So even though there's disc disease, even though there's osteoarthritic changes, even though there might be comments about encroachment or narrowing or impingement on nerves, not necessarily related. And so I do a lot of trying to convince people that I don't need to hear about their imaging so I can talk to them and examine them. And then after that, I will look at their imaging and see if the pathology that I find on my examination, if it correlates with some of those things that came up on an MRI. I actually don't care, because what I care about is the presentation, right? Because I understand that, you could have the worst looking back in the world, but you might be totally fine. And someone who has a pretty normal looking back might actually have pathology that when we go, oh, there's this very subtle change and it's actually causing a problem. And so very politely, I say to some people, I don't care. I want to know what you're feeling. right? Because that's the important bit. Can you feel? Can you move? Those sorts of things. I just went on a rant about why we wouldn't get imaging, why I don't care. When would I care, right? When are times when it's pertinent, when it's important to say there should be a picture here? Well, of course, when there's neurologic findings, right? We're talking about the bones that protect your spinal cord and the nerve roots that come out from the spinal cord down into the legs and out into the arms. So of course, that would be a time when it would be important. Again, I can't speak to everyone in the room because we've not had a one-on-one conversation. So there are times when some or all or none of those things are present, and doctors will make individual decisions based on their clinical judgment. Great question. So the question was, if I don't have the picture, how do I know? The fun question. So I have been trained both through general medical school. I know that family physicians also learn a lot about this, and then I have subspecialty training to ask questions in a particular way to find out what someone's symptoms are and the relationship of those symptoms in time to sort out, again, say there is no history of trauma. How did these things start? How did they progress? How did they change in time? And hearing that story paints a picture for me of where I think the pathology might be based on the fact that I've been studying anatomy for the last 15 years. And then I use my physical exam, and I do a neurologic exam, and I do a musculoskeletal exam. I look at how someone moves. I look at the relationship of the way their hips and their back move. I watch them walk. I watch them walk in different environments. Sometimes I'll ask them to squat. And so all of that tells me information about what's going on. I have special exam maneuvers that can give me more information about whether this is coming from a back joint, a hip joint, one of those facet joints, and then I can target and focus that. And so it's a lot more functional than a static picture. The other way I tend to describe this is if you think about a computer, there is a structural computer. There is a monitor, there's a tower thing that has all of the pieces in it. I don't know anything about machines, but like there's wires, they plug into each other, you know. And then there's software, right? And there's the whole programs that run. And you have to figure out as a doctor, is this a hardware problem or a software problem? Is this a problem with the machine, or is this a problem with how the machine functions? And there are bits about the machine that change, right? I don't know if any of you guys are cyclists, but we all have cars, right? And as our cars get older, they need more maintenance. The machine itself works, but it needs more maintenance, it needs more upkeep. Now that cars have computers in them and a whole bunch of other stuff, there might be a software problem, right? Like, what does it mean if your check engine light's going on? I don't know, but my job is to look at the check engine light on you guys and go, let me do some diagnostics. How long does this process take? Because most primary care appointments are about 15 minutes long. I am privileged. Part of the reason why I chose this specialty is because I work with complex patients, and so I am allowed to take my time. My assessments take about 45 minutes to an hour, but at the end I have a diagnosis, and that's part of my privilege. One visit. And again, if we think about the spectrum of complexity, right? My job as a specialist is to think about the scariest things and work backwards. Someone's job as a family doctor is usually the opposite. They think about the most common pathology, and then they progress to more complexity. We meet in the middle, right? If they do the common things or they go, this is weird, that's when they send things to me, and then I get to take my time and work backwards from the other end. And that's why our system, I think, works really well. If someone has a neurologic issue, or there are certain things that doctors and I know to be worried about, those things get flagged. And so it's 9 months for a routine visit. If something is more urgent or we're worried, I see things sooner. And again, I think that's why our system, it has a lot of problems. But with people that need to be seen urgently, they are seen in the appropriate time frame. As I mentioned at the beginning of this talk, if this is something that has 84% prevalence, this is something that family doctors know what to do and are good at, right? That means they're trying things and doing things with you while you're waiting. And that information to me is also valuable, right? What worked? Why? What didn't work? Why not? Those things are helpful, and the time spent is also helpful. Some of the things I actually like to see over time because it provides information. Yes or no question? Sure can. This is where I turn around and I use my hopefully infectious optimism to say, we just talked about how we dehydrate, we're stinky cheese, all these things change, not ideal. But this actually can be prevented. And we're talking about both primary prevention, hopefully, again, you're that magical person that has never had back pain, but also secondary prevention. You already have back pain, or you've had bouts of back pain. Can we make it better, make it less often, less intense, those sorts of things? There's a few key bits here, and then I'm going to get into the woods a little bit. If you think about it, if you think about just being a person in a chair, there's a certain amount of posture, there's a certain amount of energy required to be in the right space, right? Let alone standing, and here I am wiggling around all over the place because I sat in a chair all day. And so there has to be a certain amount of muscle and muscle endurance to hold everything kind of together, right? If you didn't have muscle tone sitting down, you would be a puddle on the floor or a puddle on the top of your chair, right? So certain muscles just need to be active, even just in sitting. And so if you think about doing that and how much we sit or stand or walk, what are those muscles that are almost always on? And those are things that we can affect change on. If you've got better shock absorbers in the system's gonna run more smoothly. There's gonna be less forces through stuff that's already a little bit worn down. And so that's the logic of using muscle strength and muscle endurance to support those other structures. And again, I'm gonna try and get you to drink that Kool-Aid. Thank you. And again, here's where we're going into a bit of Mythbusters, because lots of people talk about lifting, right? Did you lift the right way? Did you get back up off the floor in the right way? At the end of the day, some nerdy people who like the type of science that I like looked at the forces through the segments of the spine, depending on how people were lifting things up. And at the end of the day, it really didn't matter how they did it. It just mattered where the weight was. So, good technique is just making sure that the weight is close to your core. So you're not lifting out here, right? And you're not lifting out here, but that it's tucked in close. And so maybe there's something to be said about things like knapsacks, right? Or a push cart where you can hold something close to your core and move it, rather than having grocery bags all over the place or having to reach for a bag or turn and put it somewhere, right? So that was the only thing that was come up with, was making sure it's close to the core. I really, really worry about people that are scared to move. Those are the people that I worry about. Because if the exercise is medicine, if the movement and the muscle strength is the thing that's going to keep, the old car going, that's the thing that needs to keep happening for the back to stay as healthy as it can be and to recover the way it can. And so even though the idea of getting out of bed sometimes feels atrocious or turning the wrong way just grabs you, the people that are too scared to do that are the people that I worry about, because I worry they're not going to do well and they're going to keep getting scared to move and the pain cycle is going to build. And those are the people that I worry that it's going to turn into that chronic pain. So this is my other really big take home. That just because something hurts doesn't mean it's scary, right? Lots of things hurt. Are you hurt or are you injured? And our bodies and our brains developed in a way that, if you were getting chased by a bear or, you broke your leg, no, you shouldn't walk around on a broken leg. Bears are scary, so are broken legs. And pain tells us not to move in those situations, and that's safe. But backs are one of those things, especially with the aging back, that the pain isn't scary. It's just pain. And life just hurts. And again, a whole bunch of nerdy people have done a whole bunch of studies. And the more people move, the better they do. The more people move, the less likely they are to end up having disability in the context of their back pain. Okay. I told you I was going to get into the woods about exercise, and here we go. This is the stuff I could nerd out about all day. What I am actually talking about is just being active. It's making the decision to go all the way around the grocery store even though you only need to get milk. It's the idea of, parking a little further away because it's a nice day and you don't mind strolling across the parking lot. Little things like that, right? Motion is lotion. It doesn't have to be this ultra marathoner. I've already told you that person's going to have more back pain than you. Sucker, right? It's the only thing I have on them. And lots of studies have been done on this. They've done these meta-analyses where they take all of these studies and they put them all together and they see who's the best. And we don't know. What does that mean? That probably means that a whole bunch of different types of movement are good, right? It probably means that there's no one magic pill that is this type of exercise that's going to be the ticket. It means lots of different things work for lots of different people. The example I tend to give is you could not pay me to dance in public. You couldn't. Terrible at it. But lots of other people enjoy a dance class. Great, go do that. I wouldn't mind going to a public swimming pool, but I know lots of people that do. Totally fine. I was a lifeguard for a long time. I'm used to the gross floor. Right? But the point is that different things work for different folk, and you have to find the thing that gets you moving, right? And so I'm going to talk through this list of stuff. And these are the things that have the most evidence behind them. Walking's great, right? If you think about working on, core muscles and having to stand upright and moving, great. It's the most accessible thing ever. I'm going to skip strength training for a second. And how lucky are we that we have all of this, fresh water with public, beaches and all of this stuff where we have access to that 6 months a year, right? I used to try and convince people in Toronto and London to maybe think about joining a pool. And around here, I don't have to. I get to go 6 months of the year. You guys can go water walking or go for a swim. That's the best, right? It takes the pressure off your joints. So if you're worried about moving and you're worried about impact, the water's the best place to go because there is no impact. We don't have to deal with open water and big waves. It's pretty perfect. Really, the stronger your muscles are, the more they're able to deal with the lumps and bumps of life, probably the better we'll do. I think the knee is a great example, even though we're not talking about the knee. But if you think about walking downstairs, right, every time you take a step, your knee takes impact. Well, the stronger your quads muscles are, the more impact actually goes for the muscles instead of your knee, right? They're the brakes. So that's something that we all can actually you're I don't have to know physics to understand that one, right? The back is similar, right? We're talking about multiple layers of muscle that if with every step, if you could take a couple of pounds of force off of your back, it would feel better. And that's the idea of strengthening. That's the idea of building up the endurance in the muscles. How do you do that? I think some of the best ways of doing that are these. Yoga is interesting because there's yoga where people stand on their heads, and there's yoga in chairs, and there's, right? So it depends on the type of yoga, right? There's so many different types. Pilates is excellent, right? The whole idea with Pilates is core activation. So before you do anything else, your core has to be turned on and then you have to move. It's actually the type of thing where if you go to a single Pilates class, you can do Pilates for the rest of your life because it's just about making sure your core is on. That sort of a thing. Tai Chi is similar, actually. It's all about having a good, strong base and then moving outside of your base. And so Tai Chi has lots of evidence in terms of falls and bless you and all of that stuff. But it's the same logic of, do you have your core and your base and then actually move outside of it? And so that's the logic, and that's why I think it works so well. Does doing more core activation reduce your risk of back pain? It depends on the type of core activation, right? So something like a repeated sit-up actually places a lot of force in terms of flexion extension on the spine, right? And so if you already have some degenerative disc changes or you already have arthritis in there, and what you're doing with a sit-up is doing repeated aggravations of those things, it actually might aggravate it. And so there's different types of core activation, and there's different types of exercises that don't put those forces through the spine, or that, again, don't cause these repeated flexions. And again, to the cycling point, right, you're in this really almost hyperflex position if you're in the saddle, or are you actually overextending because your core isn't on? So different things like pelvic tucks and bridging and something called dead bugs and bird dogs and planks, right? Those are all things that stabilize the core but don't cause lots of repeated flexion extensions. And so it's conceptually slightly different in terms of having like what core muscles are you working on? And to take that one step further, if you're not signed up for next week's session, the two physiotherapists that are giving the session talk a lot about pelvic floor stabilization and deep core stabilization. And that, again, they go hand in hand, right? Those muscles that you can't see, we're not talking about getting a six-pack. We're talking about the muscles underneath that stabilize everything. Not all of us have the privilege of seeing multiple healthcare providers, paying out of pocket for these things. If you do, wonderful. We've got some excellent therapists and kinesiologists and chiros in this community. If you don't, there are some wonderful programs online, and I didn't add those resources into my slide deck, but I certainly can share them. And so these are things put together by the Canadian and the Ontario government that are programs that, again, if you don't have these outstanding resources or wait lists are very long for OHIP covered physio, they exist online. Okay, we're gonna switch gears. We're gonna play yes, no, maybe on does it work for pain control? Low back bracing. Does it work? Does it not work? There's actually negative evidence. There's evidence against this working. And so to your point, if you are wearing a brace, you're less likely to have those body awareness of your mechanics and ability to stabilize. Again, in the very short term, some people find getting that little bit of extra protection might be helpful. But again, the way I said that, so many stars and so many caution. And that would be maybe for like a day or two, right? Otherwise, it actually makes things worse instead of better. Traction. It's like getting stretched. Does it make back pain better? So there's different ways of doing it. Sometimes there's machines, there's manual traction where a therapist can kind of stretch you out like a slinky. And then there's also traction devices where you can stretch yourself out.
Like
Exactly, like the inversion table thingies. Yeah. Again, maybe in the very short term, there was mixed evidence. Everything else was not positive. And so this is something, again, if you start talking about like how much money you're throwing into a back and is it working and this and that, this is one of those things where there's actually not a lot of good evidence to say this is something you should be investing a lot in. Again, different for that very acute phase versus anything longer than 2 days.
You're not pulling her leg, are you?
Both simultaneously. I like that. Therapeutic ultrasound. So this is one of those things where there's lots of different modalities, which is the fancy term for saying things that can maybe help pain along. And one of the very common ones is therapeutic ultrasound. Lots of other people talk about things like lasers. There are multiple different schools of thought. There are multiple different ways people are trained. Part of my education was learning what I do from dozens of different people, right? To see what parts of it I like and what I don't like and what works. A lot of my training was also to figure out what the evidence is so I can best support as many people as I can. 2 things. 1, if someone tells you that they have a magic cure, run. Or walk safely away.
Swing your arms, Doug.
Yeah. Aqua walk away. There's no such thing as a magic cure. When I start telling people about the magic pill, I'm trying to buy them into exercise. That's the magic pill. If you want the cure-all to anything, it's exercise. It's okay also to try things and to buy in and to trust your therapist. There are certain things that do help. The Choosing Wisely Canada guide actually says a trial of therapeutic ultrasound for acute back pain is reasonable. It is not reasonable for long-term or chronic back pain. And so there are different times in different places where this may or may not work or may not be efficacious. I tell lots of people all the time, like if you think about having to work with someone and trust them and tell them, you know, this hurts, this sucks, this is hard, you want to have a good, healthy relationship with them. It also means you can break up with your therapist. Unfortunately, I'm the only one of me that you got. But we're lucky in this community. We've got lots of different other care providers. And so just, you know, like not everyone's your cup of tea. And that's okay too, right? Because they could be excellent for your friend, but not the right person for you. And that's okay too. You need to be improving, is all I can say. So I'm going to give this a thumbs down because it doesn't work for long-term back pain. But again, it is in the guidelines for short-term back pain, so don't take a picture of it because it's a mixed message. Okay, so this one's fun. Dry needling is very similar to massage, and so we're going to throw massage in this too. What dry needling is instead of just digging into a trigger point or a knot, they actually stick a little needle in there and they will break up your knot, but with a pin instead. And
Is that like acupuncture? It's not.
it's not acupuncture, it's even deeper actually. It goes into the muscle, and just like digging into a knot, they like dig into it with a pin and it makes the muscle jump and then it releases. It's our first green one. I mean, yeah, statistically, the right answer was, because I only gave you red ones so far. So it does, right? If you think about my weird example at the beginning where I talked about 2 muscles trying to pull evenly, if one of them is really tight and sore, trying to get those to balance out apparently has reasonable evidence, right? And so, oh, you're right. Anyway, I'm almost done. Heat also works. TENS, the evidence is mixed. This I just wanted to draw your attention to for a quick minute because lots of people talk about medications and what to do and can I take this and is it helping and all of that stuff. And there are actually, again, those meta-analyses where they look at lots and lots of studies and stick them all together and say, does this work, yes or no? And the answer to all of these is, yeah, So acetaminophen or Tylenol is helpful. It's a good pain agent if it works for you. It's relatively safe and has reasonable evidence for acute and chronic low back pain. Anti-inflammatories have a lot of risks associated with them. They do have reasonable evidence for short term. And I end up having lots of good conversations with people about the relative risk of using short courses of anti-inflammatory. And half the people in here, if I asked you had high blood pressure or maybe a touch of kidney disease and all of that, and again, individualized, talking about risks, benefits. But if you've got raging low back pain, or you really want to get out with the kids, the grandkids, or go play around a golf and do something, and you're like, my back's in the way, everything in life is a risk-benefit analysis. And so it's a reasonable conversation to say, can I take this for a day or two? And I can't answer that for you because I am not your clinician, but it might be a reasonable conversation to have to get you out there, to get you be active, and to do those things that make life life. Muscle relaxants, similar, host of side effects, but have good evidence for those short-term exacerbations, for the time that you have to sit on the train for 12 hours going between 2 cities in Europe. Again, reasonable to have a conversation about for those as needed times. You know, you're getting off the flight and then you've got a really great hike going on in Scotland the next day. How do you make sure it's a good day, right? Those are reasonable conversations to have. So, I said the same thing over and over and over again. And that is back pain, super common, so many different causes. For the most part, those causes are not scary. They are benign. They are multifactorial. They are aging gracefully-ish stuff. And the whole thing I said for the latter half is keep moving, keep moving, keep moving. And that's the thing that's gonna keep you going and keep your back strong, healthy, and hopefully not in pain. Thank you for listening to me for too long.